morning. I'm going to try and share my slides here because I know Joanna doesn't have them. And I should hopefully. All right. Do you guys have the presenter view or do you have the full screen view?
Presenter. I have presenter, Dr.
Presenter
Lane.
view? Okay. I gotta change that. Hold on. I know how to do that, but I always get it backwards, which one I'm supposed to, come on, get out of there. Now I want to go to my Teams. Stop sharing, share this one. Okay, is that better?
That's much better.
Okay, perfect. All right. I got to get to my right slide though. I don't know what it did. There we go. Okay. So, one of the reasons I'm doing this is because, you know, a lot of the mCCM HRSA grant was based off the data that we collected through the 2 different promising practice campaigns that were put out through FDR HPO. And then another reason is because I've actually been asked to present this at the North Country. I don't know the name of the meeting. Heather, do you know the name of the meeting? Some big conference for all of the North Country. That's not just us up in Lake George. So this is kind of my trial run to go through it. So what I want to do today is I want to kind of talk to you about what our collaborative care model was by integrating patient outreach into primary care. I want to go through the process of how we engage the vulnerable population, how we closed care gaps, decreased ER utilization. I'm going to share some of our statistics and data with you. I'm also going to share what we identified as our best practices, as well as the biggest challenges that we encountered. And finally, kind of talk about the potential for widespread implementation, scalability, and sustainability. So what's the timeline here? The name of our pilot program was Bridging the Care Gap, a focused approach to the vulnerable patients. Well, late 2020, NCI launched the mCCM program. And I opened my big mouth when they launched that, and I said, this really needs to be ongoing. It can't happen just once. Why can't we do CCM? Well, lo and behold, 2021, the RFP came out for the Promising Practices campaign, and I had to put my money where my mouth was and come up with a program, and that's what we did. So we were granted funding for the trial 9-month pilot, and then in 2022, when they extended it for another 12 months, we were extended funding for another 12 months, and then all of our final data was reported in March of 2023. So what was our program? What we wanted to do is we wanted to do care management focused on the Medicaid beneficiaries, a traditionally less engaged population with primary care, and an often vulnerable population, mostly because of their social determinants of health. And so what we did was we embedded an RN care manager and an outreach coordinator, and we had them each for 10 hours a week. That's what the grant funded us. Our outreach coordinator was someone who had a background in social work. We did not hire a social worker. We didn't hire a clinical social worker because we have no way to bill for that. But we hired someone who had that background, and actually we had 2 different people through the course, and both of them were people who took the position part-time while they were continuing to work toward their masters. So they had their bachelor's and they were working toward their master's in social work. We developed the program as a modified version of Medicare's CCM program. What we modified was, first of all, we required no patient consent. We thought that would be a big barrier to getting patients involved. If they had to consent to something, we would not be able to engage them and get them involved. So we required no patient consent. We did incorporate the evidence-based SDOH screening tool. We used the same one that we were using for mCCM. We didn't have a monthly time requirement. We said we're going to do this and kind of see where it goes as far as how much time we end up spending with patients. And that's one of the things we tracked. And we utilized our practice's existing infrastructure for CCM with our electronic health record and kind of our process for CCM. We just kind of expanded that to the mCCM. We set some short-term and some long-term goals for the program. Short-term, we wanted to be able to identify specific needs through SDOH screening and then work with the CBOs to meet those needs. We wanted to focus on quality interaction with patients, meaningful quality interaction, not just you have to spend a certain amount of time with them, but what is meaningful. We wanted to decrease unnecessary ER and hospitalization use. That's always a goal. We also wanted to focus on the preventive care gaps, our quality measures. What care gaps could we close for these patients? And how can we decrease overall healthcare costs? Long term, we wanted to demonstrate sustainability. And we wanted to identify the best practices and then make a program that is scalable. So what was our process? First of all, we enrolled patients. Any patient that we saw for mTCM was automatically enrolled in mCCM. We then worked our rosters. We took all of our eligible United.
Well, yes, that's okay. And I called her and she's like, oh no, and as soon as I clicked her,
can you guys hear me okay? Because someone's not muted.
Yep,
okay.
Karen, I muted that individual. Thank you.
Okay, I'm going to keep going. Thanks. So we just kept going through our roster list and we worked our roster list to see like who have we seen, who has engaged with us, who might we be able to reach out. So we would engage patients at the time of mTCM, or we would just start calling them. The outreach coordinator would start calling them to initiate engagement. And if we didn't get a hold of them right away, we would call them at least once a month just to kind of reach out, check in, and try and get them engaged. We wrote care plans before we actually saw patients and engaged with the patients. So the care manager would go through and we'd take the care gaps that we identified. We'd take what we knew from the patient based on either an ER visit or prior visits in the office, and we would write care plans that were loosely written so we kind of knew where we needed to focus when we did engage the patient. We would modify these after the SDOH screening was done so that we could also incorporate patient goals and barriers. They were very fluid care plans, and we set a lot of very short-term patient-centered goals. So it wasn't like, you know, if they were diabetic, it wasn't we want to get your A1C from a 14 to 6.5. It was we want to figure out how we can get it to a 12, get it to a 10. They were very small, short-term goals. For the ongoing care management part of the program, we reached out to patients at least once a month. We did not have a specific time requirement, as I have said. Usually early on after enrollment, once a patient engaged, we'd be talking to them more frequently because we would be coordinating care with them. But then once the kind of ball was rolling, it was once a month and it was just a quick touch base. We worked to coordinate care with the specialists and the CBOs. And we utilized our roster lists from the insurance companies to identify and close care gaps. We really worked those lists very actively. The next few slides, we're gonna go through some of our results. I'm not gonna like bore you completely with statistics, but I want you to just see some of the successes that we had and some of the things that we found. And then we're gonna talk about after that, kind of our best practices and what our biggest challenges were. So here are some of our results. We had 189 eligible beneficiaries. We have a small practice. We're not a big fish. We do not participate with Fidelis. So this was all United Medicaid, United Healthcare Medicaid. We had 106 were enrolled, and at the end of the program, 75 remained enrolled. What we found was about 45% of our patients were engaging. They would work with us. 42% were intermittently engaging. They worked with us when they needed something, And 13% we couldn't get a hold of at all or engage. And that's why you see it drop down from 106 to 75, because we just, if they just wouldn't engage, we kind of put them inactive. From our enrolled patients, we had a 54% reduction in ER utilization after they were enrolled. It was 168 ER visits before and 78 ER visits during care management. And this was just for the second 12-month period. And it was a 13% improvement over the first 9 months. So we had decreased ER utilization in the first 9 months, but we improved even more in the second 12 months. We noted a 40% reduction in inpatient hospital stays with our enrolled population. 61 patients avoided an ER visit or an urgent care visit by coming to the office for a same-day appointment. Overall, we figured 147 ER visits were avoided either by calling and talking to their care management and not having to go to the ER, or by scheduling a routine appointment or scheduling a same-day visit. We had 3 patients who dramatically affected these results and went from 19 visits to 9, 15 to 8, and 8 to 1 over the last 12-month period, which that's a lot of visits in just 3 patients. We also calculated that in the second 12-month period, 322 same-day appointments were completed for our enrolled patients. So they really started to call us and schedule same-day appointments and get seen rather than going to the urgent care or the ER. So what about our social determinant of health screening? We noted that 69% of screenings had at least one positive, one need, but almost 50% of patients declined referrals to CBOs, stating that they either knew about the CBO, or they didn't think the CBO was going to help them, or they didn't want any help. The most needed CBOs were for mental health, DSS, and transportation. Those were our 3 biggest. The most helpful CBOs for us ended up being DSS, specifically HEAP. We had huge success with HEAP. The food pantries and the Salvation Army seemed to be the most beneficial for our patients. And our biggest unmet needs, mental health and reliable transportation. Here's some more of our screening results. You can see that this is based on percent. So almost 70% of patients reported some sort of a disability. You see over 50% had inadequate or unreliable transportation. Financial insecurity is the same, and it goes on down the list with food insecurity, problems with education, all the way down to unstable employment. This was our drug and alcohol results from our SDOH screening. 70% of our patients used tobacco products. About 55 reported excessive alcohol use, and then about 15 illegal drug use. Interestingly enough, with marijuana not being an illegal drug anymore, I can't tell you where that falls in this breakdown, whether it's in smoke and tobacco products or whether it's in illegal drugs. But we did not specifically call out marijuana versus tobacco. So care gaps, preventive screening, and time. What were our results there? In the first 9-month measurement period, we identified 176 care opportunities, and we closed 42% of those. In the next 12 months, we actually identified 752 care opportunities, and we closed 59% of those. That's 7 care opportunities per patient. And when I'm talking about the care opportunities, I'm talking about all the HIDIS stuff, all the stuff that we have to close for our quality metrics, right? So we had a 604% increase in identifying them because we got better at it. We got better at the process and figuring out how to identify the care gaps and how to build them into the process. And we, from the first 9 months to the second 12 months, we still had a 17% improvement in our closure rate. Even though we identified so many more, we still improved our rate of closure. Our time spent, the first 9 months, we averaged out to 19.2 minutes, and the second 12 months, we averaged out to 17.3 minutes. We attributed our slight decrease in time per month based on the fact that there were fewer new enrollees in the second measurement period. And new enrollees take a lot more time than people who have been established. So that's kind of where that discrepancy fell, we felt. So how much did it cost us to run the program? Our operating cost for the 12-month period, the second 12-month period, was about $30,000. We had an RN and an outreach coordinator, each 10 hours a week, and it paid their salary and benefits only. We didn't calculate into our cost anything like new computers or new phone lines. We just used our existing infrastructure for that. We also did not account for any time that other people spent just with normal care on the patient, like the clinician or my office manager gathering data, because the data mining for this project was pretty intensive and we didn't really count for that in the financial cost. Or sometimes if our referrals coordinator was working on referrals for one of these patients, we didn't account for that. Our potential revenue, though, even if we were paid at 2021 Medicare rates for CCM, our potential revenue could have been about $48,000. And I will say that's a conservative estimate. The 2023 rates are higher, and we only calculated our potential revenue based on 1,99490 per month. So just one 20-minute CCM. If we were to get paid by Medicaid, that's all we were counting. We didn't factor in complex CCM, any additional CCM charges, any initiation or clinician stuff. We just wanted to keep it real simple, very conservative. We could have, if we were paid CCM rates, funded this program. But we know we're not, so we have to look at other potentials. When we did our preliminary data, we were able to get some financials from the insurance company, and it did show that we were projecting about a $7,300 per month savings for the payer. So we were saving Medicaid about $7,300 a month. And even if they were paying us $6,000 a month, they still had a net savings. And if they were paying us $6,000 a month, our operating costs with our current staffing was only about $2,500. So it is a sustainable program if we can get paid for it. And if you look at the scalability, we had 106 patients with 20 person hours. If we were assuming 20 minutes per patient per month, we only accounted for about 40% productivity. So technically, if they were billing on time, we could accommodate more patients because only about 40% of their time is accounted for in our time tracking. So it's potential that a team of 2 full-time employees could manage about 400 patients. I would anticipate more savings with longer care management. What we know from our data from Medicare CCM is that it took us about 3, 4, even 5 years to really start seeing financial benefit from CCM. So as we have longer CCM opportunities, we should be able to show even improved savings to the payer. We need more data to figure that out, and we just don't have that. In the second 12-month period, I couldn't get the payer-specific data because of the type of contract that I was in. However, we do have an opportunity to gather this data for the next 4 years, and that's with this HRSA grant, and that's primarily why everybody's here today. So super excited about that. But let's say Medicaid doesn't want to pay for it. What are some of our other sustainability options? Well, one is value-based payment shared savings. That could work, but there's some issues there, right? There's no guarantee. The payment comes long after the cost is incurred. You're waiting a year or so for financial reconciliation and then a payout and all of that. So that's a little bit tough to swallow when you're trying to finance it. And it also depends on the other partners in your contract. I mean, you could be knocking it out of the park, but if your other partners aren't, you may not get the value-based payment shared savings. We also know that United Healthcare has had quality incentives in the past. They vary from year to year. There's no guarantee. And it's likely that they won't fully cover the operating costs. I can tell you what I got from my quality incentives did not cover the cost of operation if I were to try to make it sustainable that way. But another sustainability option is one that's really hard to quantify, and that's perceived value. And this is something we definitely did experience within our practice. Perceived value is kind of how it improves the workflow of your office. We were able to improve our office efficiency through this intensive care management. So it means when that patient comes in to see the clinician, there's no longer a note on their chart that says that they need a 30-minute appointment so that we can get through everything. We can see them in a standard appointment now because the care manager has taken care of all of the other issues. It also frees up the rest of the nursing staff who's trying to make phone calls for results and answer patient calls and room patients and be out on the floor. It frees them up to be more efficient. So we actually can see more patients. And the nursing staff that has to room one of these mCCM patients doesn't have to spend 20 minutes in there updating their medication list or figuring out their screening because it's already done. We already have the plan, everything's up to date. So it's a much quicker time from the nurse. It's a much quicker time from the clinician. But again, it's super hard to quantify. How can you justify paying for these people with only perceived value? I get it. It's positive, but it's a hard sell to your budgeting people. So what were our biggest challenges? These are the two slides that I think I want to spend the most time on. One, we had some inconsistent or unreliable CBOs. I said that transportation was our biggest issue. Unfortunately, we had a patient get stranded in Syracuse by a volunteer driver. We had volunteer drivers not show up. We tried to get them into other options for reliable transportation, and we kind of kept striking out. We did feel that a lot of times we didn't have adequate resources to identify or to address our identified SDOH. So we could identify that they have food insecurity, but we couldn't always reliably help them address that. Or housing insecurity, things we can identify it, but we ran into barriers trying to fix it. We had some issues with some of our outside agencies getting some other practices on the same page. I'll give an example. We were trying to refer a patient to a specialty office. And that specialty office has the process of mailing paperwork to patients and then having them complete it and return it to them. Well, the patient wasn't going. And finally we asked and we figured it out. They didn't understand the paperwork. They couldn't fill it out. So we tried to get the office to send it to us. And it took multiple phone calls because we kept getting, well, that's not our process. We don't do that. And we're trying to work with them and explain what's happening. And so that was a little bit of a frustration. Also, we don't always have mental health resources. And I think we all know that that's a shortage in this area. Another issue with some of our specialty practices and transportation is they call the day before to confirm an appointment, but transportation has to be set up 2 to 3 days in advance. So if the patient hasn't remembered their appointment, they then have to cancel or they no-show because they can't get transportation. So that was a big issue there. Geography just being so widespread. If we only have one specialty practice in town and that patient has burned that bridge, which this patient population tends to do, then we have to try and get them someplace way outside of our geographic area, and transportation becomes an even bigger issue. Another challenge for us was a relatively weak practice infrastructure. My care managers didn't have a dedicated line. We were kind of doing a lot of chasing them down, trying to get them on the phone when patients called. I didn't revamp that portion just because it was a short program and it didn't make sense to invest in that. And then staffing is an issue. Trying to find RN care managers is very difficult. We did lose our outreach coordinator. We have to try and replace them for the continuing program. So we're in an area where staffing is always an issue. So those were our biggest challenges. What did we identify as our best practices? One, we enrolled all eligible patients without requiring consent. We just started care plans on everybody without their consent. We actively managed rosters, and I've mentioned that a few times. We really were active with rosters, going through identifying patients, identifying care opportunities. Our staff that was participating in this program was dedicated to this program. They had zero other responsibilities during their time that was committed to this program. So they weren't trying to balance rooming patients and doing care management, or answering triages and doing care management. They were just doing this. We were very proactive about our outreach to our eligible patients. So we didn't wait for them to come to us. We went to them, and sometimes we called them 4 or 5 months in a row, and then finally they needed something and they called us up and we were right there. We had everything ready. We knew what they needed and we were able to just kind of hit the ground running. As far as SDOH goes, I know a lot of practices struggle with implementing this. We approached SDOH as a conversation. We did not have them fill out a form. We asked questions in conversation form to get through the screening tool, and it gave us a lot more insight than yes or no answers. So we were really able to gauge where our patient was. We kept, I mentioned this before, kept our care plans very fluid. We set short goals, patient-centered goals. We incorporated their barriers from their SDOH screening and any other barriers they had. And we also did make sure that we followed the PCMH guidelines to cover everything that should be included in a care plan, because that's all part of our PCMH recognition. And then I've highlighted this last bullet. We maintained open availability of same-day appointments. This is a struggle for a lot of practices. It's a struggle across the region. My practice traditionally keeps 20% open same-day appointments. So for us, it was not a struggle, but it is definitely something that going forward, practices should try to incorporate. Those are our best practices. And then kind of what I thought where we go from here. We continue doing this and engaging patients in primary care. We've shown in the short term that it works, and I'm super excited that we're going to be able to do this throughout the region. I'd love to be able to work with some of our specialty practices to get them on board with accommodating this unique population, especially with some of the transportation issues. And, you know, they get discharged after 3 no-shows, but they no-show because their transportation doesn't show up. So, you know, it's a challenge for all of us. We need to work with mental health to improve the collaboration with primary care. We're still in a world where mental health is siloed, but we know by doing our SDOH screenings that it's not siloed, it's not separate, it affects their other healthcare, and we need to improve that collaboration. And then we need to continue to analyze our cost data so that we can build a case for payer reimbursement, because I truly believe that if we get enough data, we can justify this getting paid for because it will save money. And that, I am less than 30 minutes. I did it a little over 25, but I will open it to questions, and I'm going to pop out of my slideshow, and so you don't have to stare at it.
Does anyone have any questions for Dr. Williams? You can put them in the chat or go ahead and unmute yourself and ask away.
Hi, it's Marianne from the Community Health Center of the North Country. Do you have case managers already? So we have case managers who are already doing this similar work. And we have a dedicated RN for our care management. So the extra staff that you put on, was that on top of that? So did you already have case managers?
Are your case managers RNs or just?
No,
Okay, so I have an RN, a full-time RN who does my Medicare chronic care management.
Yes.
And I hired an additional RN to do the mCCM pilot program. But when I hired her, I knew that our Medicare chronic care management was a little bit oversaturated. So she actually works for me 30 hours a week. So I
Right.
have 1.75 FTE RNs in my practice. And she committed 10 hours a week to this program. And when she was doing that, she was only doing this program.
Okay.
So I did hire her. The outreach coordinator that I hired specifically for this program. And at the end of the grant, I did not keep her on.
Okay. Yeah, because otherwise a lot of that is very familiar to, the challenges and stuff that we're already facing. So thank you.
Dr. Williams, it's Tracy Leonard. Thanks for the presentation. It's great to see the outcomes that you've presented here. Just a quick question relative to the pilot results. For the 42% who were intermittently engaged or the 13% who wouldn't engage, did you see any similarities in like their primary diagnosis or certain demographic?
I don't think we dove into it quite that deeply. We were trying to track so many different things. A lot of it, I think, just boils down to the different personalities of this unique vulnerable population. We didn't look for any trend, but nothing was glaring to us that had anything to do from a diagnosis or substance abuse or mental health kind of background. Because we had a lot of our engaging patients had significant substance abuse issues. A lot of our intermittently engaging patients didn't. So I didn't really ever know that was that we could find a trend there.
Okay, thank you.
This is Aileen from NERCL. Again, thank you for the presentation. I'm not surprised by your results because this is, people with disabilities is our bailiwick. That's what we do. I'm a little disappointed that the community-based organizations weren't as helpful to you as you had hoped. So I'd like to hear more about that, and that could be offline if you have feedback about how NERCL was, or if you referred to NERCL. I don't know if you referred to us or how it went. I would share, though, in terms of transportation. So this is new as of this week, I think. We have a partnership now with Volunteer Transportation Center where NERCL is putting in our paid staff 2 days a week to drive their wheelchair accessible van. So it's NERCL staff, VTC's van, to try to improve that consistency of someone showing up for rides. So hopefully that, and I did not know about this project or its results before now, but hopefully that is something that you can use. And also share that NERCL has, I think we're up to 13 community health workers on staff. And I didn't know if you referred to any of the community health worker projects, whether it's NERCL or the North Country Prenatal Perinatal Councils project. There's a few community health worker projects out there. I didn't know if you had used any of those resources in the community.
So in the past, I will speak to that. And one of the reasons why I was so passionate about doing this program is back, when DISRUP first came out, we were notified of all these community health workers and it was going to be great. And they were going to take these patients and they were going to get them everything that they needed. But what we found as primary care providers was there was absolutely zero communication. There was no collaboration and there was no communication. So we didn't know what they were doing. We didn't even know they had a community health worker. We're out here floundering trying to get them to the cardiology appointment, and we had no idea that they had a community health worker. So there was not a lot of collaboration and integration, and that's where I think it needs to go in the future, right? I found by embedding that person in my practice and that person working with the SJOH needs with an RN right next to her working with the medical needs, that's where our success came from, because I wasn't relying on anybody else. There was no communication breakdown. And so you know, that would be my bias there is we've tried to function in that environment and we weren't as successful because of the lack of collaboration. The fact that we're working to improve transportation, I'm super excited about. One of the next things we really need to address is, you know, requiring 2 days for somebody to schedule transportation. If they might be able to get an appointment in the office today or tomorrow, but they can't get transportation. So what do? They go to the ER because they can get transportation to the ER.
Right. And that's, unfortunately, that's bigger than what NERCL staff and VDC are going to be able to function. That's MAS. That's a statewide problem with the contractor, the state contractor. And yeah, yes, I agree with
for
you
sure. But
completely.
I think if we can keep having the case points of saying, you know how much money you could have saved if you could fix it. That's why we need the data. That's why we need to continue gathering the data and reporting on the data. And yeah.
And then taking that advocacy statewide, taking that, now we have to go up above the agency complaint, because the agency complaint still isn't seeming to, it's more political than that, I think. But thanks again for your feedback.
Hi, Dr. Williams. My name is Felicia Parker. I'm from North Country Family Health Center. I just had a question about how you were documenting the SDOH screening results within the system, and then how you were pulling that data, whether or not you were using the Z codes to do that in order to be able to sort of pull out those needs that you had shared in that one graph screen.
That's a great question. How we are documenting it, we use Medent for our EMR, just so you know, and Medent has a electronic version of the evidence-based SDOH screening tool. That's the version that we use, so we can pull positives from that. One thing we didn't get super good at was pulling in the Z codes. That's been a process. We're getting better and better at it. But the Z codes are super important because that helps with our risk stratification. So we didn't actually base these results on the Z codes. What we really did throughout the pilot program, which is not something that's really sustainable going on because it takes a lot of time, but we kept a lot of spreadsheets. Like our outreach coordinator and RN kept a lot of spreadsheets and kind of ticked a lot of things off, just kind of trying to keep track of all the data. Going forward, we could pull it from our SDOH screening tool in Medent, but as we were just learning how to kind of do that and document it, we kind of did duplicate efforts to keep the numbers in a separate spreadsheet.
Okay, thank you. And then how were you documenting? I know you spoke about some of the challenges with that communication between CPOs, but how were you documenting sort of closing that referral loop? So, if you were to connect a patient to, say, the Urban Missions Food Pantry, how were you documenting that you close that referral loop?
So we would use our CCM flow sheet. So we have a flow sheet that is how we track our time, and we would use our CCM flow sheet to kind of make a note of that and document. And again, we did it on a separate spreadsheet. We duplicated a lot of things that I wouldn't recommend duplicating, but it was really for data mining for this particular thing. When we do an actual referral to a medical practice, we have a very cut and dried process for doing a referral and getting a note back and then closing that referral. CBOs are a little more loose in that because we don't necessarily get anything back. So it was more of a conversation documented in the mCCM flow sheet that said, we referred them to the food pantry. They got this, they know they can go there every Tuesday of the month or whatever. So it was more of a narrative.
Okay. And then just one last question. Just wanted to kind of get an idea of the duty. So you had an RN, care manager, and then your outreach coordinator. So was the RN doing a lot of the patient interaction duties in addition to the care plan? Or was the outreach coordinator doing some of that, some of those patient interactions?
So typically, the outreach coordinator was doing a lot of the report reviewing. So our care opportunities and kind of going through those reports and all of that. Our outreach coordinator usually was the one who did the SDOH screening with the patient. So the outreach coordinator would make that initial contact and do the SDOH screening with the patient. But if the outreach, because they were here different 10 hours a week, so they weren't always, they kind of overlapped a little bit. So the RN would certainly do the SDOH screening with the patient as well. But the way we kind of tried to set it up was that the RN was focusing on the medical concerns, the getting them into the pulmonologist and making sure their sleep apnea is treated and that. And the outreach coordinator was focusing on the SDOH stuff more, okay, these are the CBOs. So she was the one working more with the CBOs than the RN was.
Okay.
Does that answer the question?
Yes, thank you.
I think
And
there's a question in the chat here as well.
there is. Do you want me to read it to you, Dr. Williams?
Sure.
Okay, so it's from Tracy Leonard, and she's wondering how your practice approached the mCCM element with providing 24/7 access for urgent needs.
Well, the same way we approach it for regular CCM, it's a requirement for CCM and it's a requirement for PCMH that patients have 24/7 access to us. We have a provider on call 24/7. So patients can call after hours. We just take our computers home. We have VPNs. I will say one of the concerns that we had by engaging this population and them knowing that we were available 24/7 was that we would see an uptick in our after hours calls. And I can happily report that that was not the case. Because the first 9 months, we actually tracked that to see how many after hours calls we were getting from these patients. And it was so insignificant that we didn't continue to track it.
Any other questions or remarks anyone would like to talk about? I think one thing I want to bring up is that, this has a lot to do with collaboration. So there might be, care managers or housing people who aren't quite sure like what their role is in this grant. So the hope is that there's going to be more communication and collaboration between providers' offices, CBOs, and care managers. Like the instance that Dr. Williams was talking about with transportation for a same-day appointment. If that office is coordinating care with a care manager, they would be able to reach out to the care manager and say, hey, Joe has an appointment coming in the next 3 hours. Can you help arrange transportation for that? Because transportation is available through MAS for same-day appointments, but it's not easy to get, and it's a long wait on the phone, and you have to follow up with the like yellow cab or the provider for that transportation. So this is where collaboration is great. It's going to make sure that that individual can get to their appointment. So I'm really hoping that everyone can kind of see their value and their place in this grant and what they can do to support, consumers and patients with the providers. But if we don't have any more questions, we can wrap it up. Anything else you want to add, Dr. Williams?
I don't think so. I mean, I guess one thing I would ask is if you guys have any kind of constructive feedback on the presentation itself, like is it too much statistics, not enough statistics? I'm going to be giving this to a group and I have about 25 minutes to do it, and I was just over the 25 minutes. So it's kind of rushed, but if you guys have any constructive feedback on that, feel free to fire me off a message or let Heather know and she'll pass it along. If you want to remain anonymous, that's fine.
I just want to thank you for all the work that you've done for our community. I know the impact that this program has made, and we're just absolutely thrilled that we're able to continue it with this grant. it's wonderful, wonderful work. So our next all partner Touchbase will be on December 6th, which seems a long ways away. But if anyone has any questions for Dr. Williams later that they want to fill, that they would like a follow-up on, please feel free to email me or Joanna. Any suggestions about her presentation, you can also forward to me if you would like. So, but again, thank you everyone for participating, and thank you, Dr. Williams.
Yep. Have a good day, everyone.
Have a good day.